Hey, welcome everybody. We are back. We are back with the We Fix Pain podcast. This is episode number 17, and we have a guest, and I'm excited to have in the house, well, actually remotely, Dr. Craig Liebenson. Doc, welcome to the podcast.
Hey, Dino. Thanks for the invite.
Thanks for joining me. It's been great conversing with you over the years and picking your brain. I'm looking forward to, this next 45 minutes to an hour of just getting some really important parts that we can help our listeners and, more importantly, help our patients and our communities with. The topic of conversation today is creating resilient humans through resilient programming. But first, a little bit about our podcast. I'm your host, Dr. Dino Pappas. I'm a sports and rehab-based chiropractor out of Austin, Texas. On the podcast, we focus on musculoskeletal topics like injuries to muscles, tendons, ligaments, joints, and fascia. We address things like assessment, diagnosis, treatment, and rehab, and management of acute and chronic pain-related conditions. We thank you for listening and watching our podcast and humbly ask, if you like the material, please subscribe and turn on those notifications. This podcast is on Spotify and Anchor under the We Fix Pain podcast, and also on YouTube under my name, Dr. Dino Pappas. For those that don't know Dr. Craig Liebenson, he is a master. To watch him work and perform and his art is like watching a maestro, like watching a great symphony orchestra. And I've had the pleasure of taking several classes of Dr. Craig Liebenson over the years. Some interesting information. He's the first healthcare provider in California to receive a certification of recognition from the National Committee for Quality Assurance on Achievement for delivery of quality back pain care. He's the founder of First Principles of Movement that's dedicated to promoting healthy span, quality aging, and preventing disability by addressing the inactivity crisis. He's engaged in research with Professor Stuart McGill, who I follow very closely, and I appreciate all the work he's done on the spine care world, and actually in human performance as well. He's the founder and director of LA Sports and Spine. He served on several editorial boards, including the Journal of Occupational Rehabilitation, PM&R, the Journal of Bodywork and Movement Therapy, and the Journal of Manual Therapy. He was the first ever chiropractor on the McKenzie Institute U.S. Board of Directors. He's the editor of Rehab of the Spine, a patient-centered approach, which is now in its third edition, and the Functional Training Handbook. He's been a consultant and team chiropractor for the LA Clippers, that other team in LA. Sorry, Craig.
Right.
And
I agree.
Yeah, I'm a White Sox fan, so I kind of get it. The Cubs are the big boy in town. The White Sox are the other team in town, so I get it. And he's been a consultant for the Diamondbacks, the Seattle Seahawks, EXOS Performance, Boston Sports Med Group, Perform Better, as well as provided care for numerous professional athletes in the NBA, NFL, Major League Baseball, Olympians, elite powerlifters, and professional cyclists. On a personal note, he is a proud husband and father to two wonderful children. I see your pictures of your son, especially his baseball prowess. And he's found a way to clone himself and figure out how to fit 36 hours into a 24-hour workday.
Much to the chagrin
Doc,
of my wife.
That's right. Doc, once again, thanks for joining us.
Thank
So
you.
what's your superhero origin story? How'd you end up in chiropractor, and how did sports and rehabilitation become your niche?
Oh boy. Chiropractic was an interesting journey. So I became a vegetarian when I was 15 and grew up back east, and people kind of gave me a hard time about it. And I didn't do it for health reasons, but going through university, I studied philosophy, and I came to realize that living in Boulder, Colorado, kind of like Austin, Texas, that there was a whole lot of people into alternative lifestyles, and in having to defend my diet, I realized that actually it was a pretty heart friendly diet, and one thing kind of led to the next, and philosophy doesn't really lead to a specific skill that is employable. So I was a bit of a lost soul, not knowing what to do when I graduated. But fortunately, a buddy of mine who was just a year older than me started chiro school, and I thought, I could be like you are, Dino, I could be like a sports medicine doctor. I could be like a nutritionist. I could be an alt med healthcare professional. And I decided to go to chiro school in spite of the fact that I had not had positive experiences with chiros. I'd been to three because of various back injuries growing up. And they all made me just shake my head. And, one thing led to
Still
the
shake my.
next. Yeah, one thing led to well, we all have this little complex where, if somebody asks you what you do, if you're a chiro, it's like, um, yeah, I'm a chiro and I'm proud of it. But it's not what you think. Like I'm not a backcracker. So, but I think the second half of your question, as far as the rehab side, um, I was influenced by Dr. Carol Levitt, who was a neurologist from Prague, and he wrote a book called Rehabilitation of the Motor System, and focused on function, much like one of our chiro mentors, Dr. Len Fay, did. And this opened up my eyes to parts of the physical medicine, musculoskeletal medicine landscape that got me really excited. And things have changed in our space around 2000. So, good 12, 13 years into my career after getting licensed, we saw a pivot towards strength and conditioning, people like Mike Boyle and Gray Cook. And that really transformed the path that I was on. And I realized, to your title today about resilience, just how important it is to build robustness. And I think, going all the way forward, so that we take this journey, from the beginning to the end, as far as that goes. With the pandemic, we learned a lot about healthy aging, and we learned that people that are, 90 or 80 who were hospitalized or died because of COVID were more likely to not have any kind of good physical activity in the 2 years prior, and just how important PA was to them. And specifically, 90-year-olds suffer from frailty and sarcopenia and muscle wasting and need strength training. And then it begs the question to every chiropractor and dry needling, acupuncturist, physical therapist, etc. out there. It begs the question, why are we managing people away from load, to your question about resilience, who are 30 and 40 and 50? And yet, if somebody's 90, the most important thing is to build muscle strength and muscle mass. So the whole thing just doesn't add up anymore. And that question has driven me the last 20 years of my career, and has gotten really focused in the last 3 or 4 years, I feel.
Yeah, and I it's interesting. I came up as an exercise science major, and we talk about these points, and until it becomes a lived experience, I'm now in my 40s. It does not hit home. And then when you start to see the effects on your parents and then your community, inactivity, and then the stereotype, and you realize we're up against something that has been ingrained in people's mind, that physical activity should decline. You shouldn't have fun with sport. You should be less physically active. You should put all your eggs in the basket of work and stress and life, and not counterbalance that with mental resiliency, physical resiliency, capability, play. It's really set the stage for what you're describing, this massive exposure of the cracks in our system when a worldwide pandemic was set in motion, right?
Well, it has a silver lining. What does the Grateful Dead lyricist Robert Hunter say? He says, sometimes you get shown the light in the strangest places if you look at it right. And that was the pandemic. In the chaos was an opportunity to kind of innovate and creatively uh, 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 almost destroy things that were broken. And I think we're seeing a huge pivot in not just the health, but the fitness landscape now, away from, not just the medical industrial complex and big farm, but also fitness and chasing gains. It's not about gains. It's not about chasing fatigue. It's to your theme for today, for this pod. resilience, because people come and see you and they see me, whether it's in Austin or Los Angeles, or whether it's in Delhi, India, or Bogota, Colombia, it doesn't matter. They come in to see somebody with musculoskeletal pain thinking that we're going to provide a quick fix. And there are no microwavable solutions. We want to kind of take a dispositionalist view and unpack what were the precipitating, predisposing, and perpetuating factors, which usually are non-physical. They're not even usually bio. I'm not ignoring bio. I'm never going to ignore bio, but there's been too much down the bio rabbit hole, either biomechanics or structural pathology on scans. And people think they're injured and that there's a direct correlation of tissue injury to symptoms. And yet those very beliefs are more impactful for how fragile a
Yeah.
person feels than the degeneration, the torn labrum, the actual injury, their poor biomechanics, weak core, you name it. Not that those things aren't important, but once the lid is off the Pandora's box, it's very hard for people to take a broad view and to look at the non-physical factors. But yet those things are the cornerstones of everything that I do today. I want to help people with getting sleep, to your point, lowering stress, having countermeasures, whether it's mindfulness, whether it's an anti-inflammatory diet, a lot of zone 1, zone 2 training. I want to build up their mitochondrial foundation and metabolic flexibility so that they're anti-inflammatory. I want to ask, as Katie Dabrowski in Miami, one of my faculty, asks of all of her urban athletes or hybrid athletes, so what's your program? Because they come in thinking she's going to dry needle, and they're looking around and they see squat racks and turf, and she asks them, what's your program? In other words, like EXOS said, how are you training for the game? Because
Mhm.
maybe it's not the load that broke you down, it's the load you weren't prepared for.
Yeah, that's an interesting spin on that about preparedness. And preparedness comes in multifaceted capabilities, and you start putting the sum of the parts together. And I think that's kind of what you're describing. If there's a flaw, we want to be able to find and expose that flaw, not hide it in the background, because that's going to impact your health more. Which gets us into the topic of programming and identifying what to program for. And we're going to get to that, but let's finish the get to know you phase here. All right. I like telling stories. I'm a storyteller at heart. I know we're deep into it, but let's tell that story. So, some fun things about you. Um, what book? This is the 5 random questions. Can't prepare for it. What book would you recommend somebody would read twice to change their life?
I might go way back on this one. Walden's Pond. Henry David
Interesting.
Thoreau influenced me a lot as a youngster. He voluntarily incarcerated himself in order to seek that solitude. And of course, the pond, Walden's Pond, was a place where he got away from, an earlier time where there weren't even so many dopamine rushes on our brain. But he even saw it then, how important it was to reflect and to ponder. And so that would be my first instinct.
How about the next one here? The mom and dad, I made it moment, where you can look your parents in the eye and say, I made it. I finally made it.
Well, that gets back to the whole chiropractic identity issue. So probably, uh, probably they were happier that I was going to chiropractic school than if I was uh, still kind of
Philosophy
a
major.
rebel. Yeah, well, I was a rebel, and I did my dabbling with things that are popular today, like hallucinogens. But in that time, people were very scared of that stuff. But I think that was sort of a concession on their part. So probably when the first edition of my book was published, that would be the one that they felt some pride in.
Yeah, I got my hands on that copy as an athletic trainer in the 90s. And I was like, I don't know very much. And then I was fortunate to pick up the second one, another critical time in my juncture, right in the middle of chiropractic school, where you're thinking, like, this doesn't make sense. Like,
Hmm.
why am I doing this? because I had the benefit of treating patients as an athletic trainer prior, and then going into this philosophical slash hard science, getting away from patient care and learning about what make people tick. So I was able to pick that second book up at a critical time in my juncture. So thank you for that.
Well, I want to thank
Um,
you and your athletic training background, because one of the things that helped my pivot as a young chiro student was I formed a sports injuries club like first term in with a classmate who was an ATC.
hmm,
And he was teaching us taping, and that got the wheels turning because I always loved sports. And then I realized, these other things are important. Then I get exposed to the Prague School through Levitt and Yonda, and they're all about how you can't ignore the muscles. It's not just about bones and joints, and not just tight muscles, but weak muscles. So, these things all kind of create this sort of cascade.
yeah, there's a synergy in conservative neuromusculoskeletal care, and we can learn from people in different professions of different titles and different fields. And if we don't apply their lessons, shame on us, right?
Yeah, we have to have an open
Um,
mind because we've all failed, so we better fail forward.
guilty, lots. And the worst is you don't even know when or why, right? Like, at least the older you get, you realize there's a system in place. And when you don't get that anticipated result, you have a process in place to say, that's where I failed and that's where I can pivot next. But early on, no clue. What's your superpower?
My superpower,
Oh, yeah.
I feel like, and it wasn't always this way, but I feel like it's giving people space to tell their story. So they come in, they say, "Let me give you the 5-minute version," after I ask them to tell me their story, and I go, "No, we have we have all the time in the world here. Take your time." And just giving them that space to tell their story. For me to be passionately curious about people's story has been the biggest game changer in my ability to see the through line. And it's not it's not what I was trained in, and yet it's a skill that I've acquired, and I feel like I've earned it through effort. And I see incredible results from empathetic listening. I think that the person's story, like we hear it in medicine a lot, listen to their history. It's telling you the diagnosis.
Yeah. 100% concur. I've come full circle on that to, uh, like giving people time. If they need it, I'm going to give you that time because it's important for you to get it off the chest. The one that irritates me is the patient that says, "Didn't you read my intake paperwork?" And they're so, I got to remember, like, I'm in Austin, so we get a lot of engineers and type A
Uh,
educated, motivated people. And time is a very precious asset. So when they fill out that paperwork and you're asking them, take me through, what can I do? Simple question to help you today. How can I make this better for you? And then they answer like, haven't you read my paperwork? I'm like, I look at them like, your story is not in there. You haven't told me your story.
Well, and
You've told me some
if they did
information.
say that, I can pull out the fact that I did look at it and ask them some questions. But we've learned about motivational interviewing, and the first thing is listening, and then to that engineer in Austin's point, we should be able to repeat back to them what they've said. So if that's like creating a little tension, I'll repeat back what they said and then go deeper.
Gotcha. So what is your treatment style? What is your methodology? If you had to, in a couple words, describe in your evolution where you're at now from a assessment, treatment, management standpoint, how would you describe what your style is now?
I call it a gap analysis. So I want to identify where they are and what they need, and then the plan. Create a game plan to bridge the gap from where they are to where they need. So it's like an F1 situation. What are their demands? What are their goals? So I have to do a deep needs analysis dive on what their goals are and what they're having trouble with. what their activity intolerances are. And then I'll look at what they have. So I have to look at the bandwidth of their capabilities, and where there's a gap between what they have and what they need. That's what we're going to bridge with rehab. So what is rehab? Rehab ain't soft tissue work. Rehab is not passive. Rehab is active. Rehab is training in the presence of injury, as Philip Glasgow said in England. And the ultimate rehab is teaching a person what to do for themselves, which is something that Dr. Levitt instilled in me. And now we see that the science is showing is the highest value care that we can offer. And it's not easy. Like this idea that, it's about compliance and it's on them. No, it's about collaboration. Just thinking of it as compliance is a problem on our part. It's collaborative and it's supported. So self-management is nothing without support. And we have to create the context or the environment. And also explain why, the why behind the what. So it has to be relatable to them. There has to be this process that's called sense making. And these are all packed into this, as you call it, this process that I follow today, is teaching people how to do the gap analysis, how to find a safe starting place, how to give people a positive experience with movement, um, how to give them tangible hope and an achievable plan.
What are 2 or 3 tips to conduct this in a time efficient manner that's very impactful for the patient, that also gives you as a provider really good data points to create measurables, or really good data points to create at least a roadmap to success? Like, what have you found, two or
Sure.
three really key points on that path?
Well, we have to measure things that matter. And so it starts from the listening. We have to, Matt Jordan, who's in Calgary at the Sports Science Institute there, he says you have to determine what matters. That's the listening. And then you measure what matters. So it's different for different people. A golfer, I may need to be looking at how they handle rotation. Okay, a runner, I may have to look at how they handle landing on one leg, since there's 5 to 8 times body weight. So there's KPIs, or key performance indicators. A 70-year-old, it may be how they get up and down from the floor, which is half kneeling. It's a lunge, and their balance. An 80 or 90-year-old, it may be their ability to do a squat from a chair height unassisted, because that's the number one determinant of independent function and whether they go to a assisted living facility or not. So it is different. And those are some general qualities. There are some universal things. I like to see how everybody squats, how everybody lunges, how everybody pushes and pulls and carries. This is something Mike Boyle has talked about, where the lacrosse dad and the tennis dad and the hockey dad are asking Mike's trainers in Boston, Mass, why is it our kids are doing the same rear foot elevated split squat when they play different sports? And it's because there are ABCs. And so there are universal ABCs, which are general, and then there are more specific things based on the KPIs of that person's demands.
How do we know when to program, or when to go general, and how do we know when to go specific?
I always start general. So that's a great question. When? So I don't care who you are. When you come in and see me, the very first thing I want to know is, are you hitting? And I know that, generally speaking, 86% of people are not going to achieve these landmarks. Are you hitting the World Health Organization physical activity guidelines? And they're very simple and they're very general. And I always want to start with them, because if you hit them, you're creating an anti-inflammatory state and you are becoming more robust. So what are they? 150 minutes a week, about 30 minutes a day, 5 days a week of moderate to vigorous physical activity, basically getting your heart rate up. Basically having pauses in your speech, which would make it zone 2 training during the cardiovascular aerobic training. That's number one. And about 40% of people hit that, so only 60% miss it, which is still a lot. And secondly is resistance training, which only about 25% of people do. And only, as I said before, 14, 15% of people hit both. We need both, and they're both general. And to my earlier point, all of my 30, 40, 50-year-olds think they shouldn't do resistance training. it's dangerous. What if I do it wrong? They have discomfort. Hurt equals harm. The tissues are vulnerable. They're fragile. Well, I want to pivot from my cup being all fragile to my cup being all resilient. And there's going to be a process where there's a little bit of green and blue in there, where it's somewhat fragile and somewhat resilient. But the way we get from fragile to resilient starts general. Let's huff and puff to get you anti-inflammatory, to get some cortisol levels regulated, to get you out of a sympathetic nervous system state, number one. And number two, let's get you doing some resistance training, because that will violate all of your expectations about being fragile. and then we can get specific later.
Yeah, you want to flip the narrative from fragile to unbreakable, and not like unbreakable. I'm gonna go base jumping. Like unbreakable is I can pick up that dog food from the bottom shelf at 75 pounds and no factor.
Yeah, and I don't want people to feel like they have to do things right. There is no right. We're built with so much redundancy in our nervous systems that was a poison. That was a virus that I gave people when I was introducing corrective exercises. This turned out to have a very dangerous dark side, and so many people now are afraid not to suck their navel in, or afraid not to brace their spine or maintain a neutral spine when they're not even hitting the PA guidelines. This is a huge iatrogenic side effect of some of the best intentioned people, including myself. I feel like I had good intentions, but turns out that I created more problems than I solved.
Doc, so over the years, we've kind of morphed away, and the literature's kind of morphed away from this cueing that you mentioned and kind of policing perfectionism to let it fly, and we'll only tinker with it when it presents as problematic. Your evolution along that line kind of grasps this research and this kind of field here. And is there something that you will say to cue a patient now? Like we have a patient in that setting, I'm not sucking in my navel, or I'm not bracing, abdominal bracing. Is there a cue or something you can tell our providers or our community members that you'll say to kind of break the ice on that?
Yeah. So, we all have these images in our mind of god awful form, and that we wouldn't allow it. So I generally follow what Pavel Tsatsouline taught in the very first video that he presented to the world. Of course, for those that don't know, he is the godfather of the kettlebell, brought it over here about 25 years ago. And his first video was a riff on Bruce Lee. It was called Enter the Kettlebell. And he was teaching a clean exercise, and where you're taking the kettlebell from the floor and you're catching it here. And he said, you don't want to cast the bell. This is going to hurt your shoulder. So poor form, if you're casting the bell, it could be a mechanism of injury if you have too much weight or you add too much volume. But rather than telling a person to keep the arm in, he didn't do that. He didn't give a negative cue, which we've done studies and we've seen from Gabrielle Wolf, the real lioness in all this, that giving negative cues impairs performance. But giving a positive cue, keep your arm in, also isn't as good, because it's an internal cue, as guiding by the side like Alfred and creating an environment where they problem solve themselves. That's where motor learning occurs. So the first case where you're teaching a person what to do, that's motor control. That's what I did for 20 years. Motor learning is where you create an environment. This is constraints-based motor learning. This turns out to be a 60 or 70-year-old science of skill acquisition that everybody ignored, who was a trainer or a physical therapist or a rehab quote unquote expert. But coaches like John Wooden always believed that you should guide by the side, let the environment do the coaching for you, create a challenge, and the person had to solve it. It's how you would coach horses. You can't give them cortical cues. You create an environment. So Pavel said, you shall stand against the wall. Now the wall shall be your coach. And now you have to lift it in tight. And that's what we do. So in China, obviously movement is a universal language. I can't be queuing in real time waiting for a translator. So I would get 8 people on the stage. I'd have an audience of 300-400 people. I would have everybody get in a high plank. And Dino, everybody knows that most people's plank isn't that good. Most people's plank is not a plank. Most people's plank, either they're sagging into a
Or
sway
tense.
back, or they look like they're doing a down dog.
Yeah.
And sometimes they're here, but then the head is like protruding, it's dropping. So I would shoot a picture with my iPhone of each of these people, and I would show the picture to the person. And I would ask the audience, I would go, what would you do? What would you do? And they'd all start to throw answers. Oh, teach them to brace, tell them to do a pelvic tilt, suck their navel in, squeeze their butt, tell them to flatten their back, yada, 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 yada. I would just show the picture, and then people would improve more than they would improve, usually from weeks of verbal coaching, just at the speed of light, just seeing it as the picture hits their retina. People's ability to change is so remarkable if you create the right environment. Another thing we do that some of my staff called truth serum or lie detector is we would have people do the planks or beast crawl exercises or bird dogs with a yoga block on the back. And now, of course, when you do a bird dog and you kick one leg out, most people rotate. Yoga block falls off. I didn't have to say anything. Person would go, oh, let me try that again. They're engaged. They put it
Yeah.
on their back again, and they figure it out in the speed of light. I never did manual positioning. I never did cueing, etc. So this is called gamification. And when people figure it out for themselves, it's sticky. They feel accomplishment. It's part of how we teach all of our courses. We use a lot of gamification.
Yeah, the natural reaction is when you try to touch somebody to put them in the right spot, they do the opposite of what you want. They stiffen up, right? And it is exactly harder to move them into the correct position in a bird dog or a dead bug, right? Like you don't soften and stiffen, you brace, right? And that's the exact opposite. So creating a learning experience through a simple like visual cue. You're doing this, man. You know what to do. Fix it. Or like ground reactive force. It's the ultimate. It's the ultimate teacher, right? Like I had a patient doing a scapular exercise for stability, and like, hey, all right, it's easy. And I'm like, well, we can make this hard. We can just put you on the ground and make you use your body weight, right? And again, that ground is pushing up against them, which is driving that learning, creating that learning experience is, yeah, like you said, it's tricky initially, but the more you get it, the more you understand the concept, the more you can play with it. And like you said, play jazz. I've heard you say that at a couple seminars as well.
Well, and to your point, the if you can find a measurable, because that which gets measured gets managed. If somebody's doing a weight and they're doing a bicep curl, and you give them 15 pounds and they can do 10 easily, and now you give them 20 and they can only do 5 easily. They can't wait because you're going to tell them, listen, in 3 months, maybe even sooner, maybe in 6 weeks, you'll be doing the 20 pounds for 10 reps. And now they're bought in. Now they see that there's a goal, there's a general timeline, and it all makes sense. Like, yeah, that'll happen. I just have to repeat this. I just have to practice it. So we don't want people to be paralyzed by thinking they have to practice everything perfectly. Rome's not built in a day. And one of my favorite recent podcasts that I follow is called Sportsmith, I think. And they have this coach from England. No, he's from Saudi Arabia. And he talks about coaching ugly. That if it's perfect, you're not challenging the person. That's a comfort zone. That's their cage. They're not growing. They're not learning anything new. There's no potential for adaptation. Obviously, we have standards. So there's a certain standard. And if it doesn't meet the standard, then we have to make it easier. But sometimes if it's wobbly, the person doesn't know. Why would we call that out to the person? We don't want to shame them. We want them to have a positive experience with movement. I want them to come back. I want them to be motivated. If you're always correcting people, there's nothing that takes away motivation more.
How do we find the point where adaptation and compensation. It's a fine line. We want to create a positive compensation, a positive adaptation, but we don't want to train something that is potentially injurious or potentially detrimental to the long-term goal. I've been guilty of that. I've done like bust your balls 6 hours with 45-pound rucksack going up and down, 10,000 net square feet. And the next 3 days I am toast. I can't move. I don't want to train. I'm in central nervous system fatigue, right? CrossFitters the same way. So how do we navigate? Because there's a fine line between too much, too little, and then that sweet spot where you get that adaptation that we want. How
Yeah,
do
I'm
we
glad
find
you
that
asked that.
spot?
That's a brilliant question. So Goldilocks and the sweet zone is an art. One of the things we'll look at is their sensitivity if there's pain. So not every hurt equals harm. 0 to 3, or it's green, and there's discomfort, but hurt doesn't necessarily equal harm. Yellow is uncertain. We don't know. It's in the middle. It's yellow. And then there's red, and everybody knows red. You see a grimace. It's 8. They'll say it's 10 out of 10. They'll say it's 12 out of 10. So one way is with the traffic light for pain. Another way is with their form. So I always want to follow what the great Russian sports scientists or exercise scientists from Verkhoshansky on down have preached, which is don't empty the tank. So we always want to leave about 2 reps in reserve. So our sweet zone is something where there's maybe 2 to 3 or 2 to 4 reps in reserve. And we can also look at velocity. So we can measure, I've got an app, the app doesn't cost anything. I can measure velocity of the trap bar or another bar. And when we see that they're losing concentric speed, I might call the set. When we see that there's poor eccentric control, so loss of concentric speed, loss of eccentric control, and reps in reserve, all those things together help us find that sweet spot. The sweet spot, as far as rating of perceived exertion, is about a 6 to 8. A 6 to 8 RPE is about like 2 to 4 reps in reserve. So if they're doing 10 reps and they could do 10 more, there's not going to be, to your question, any adaptation. It's too easy. If they do 8 and there's 2 quality reps in reserve where they're not slowing down on the way up, I found a sweet spot, and we can train that. So it's scientific and it's repeatable. People understand RPE when you explain it as reps in reserve. They understand the Goldilocks principle of training when you explain that you want them not to empty their tank. And the final piece of the puzzle, because that's all for strength, when you get to aerobic, we don't want to chase fatigue. We are not chasing fatigue. That is not a badge of honor. We need zone discipline. We want to do a lot of easy, lots of Z's, lots of easy. There should be no more than like a pause in your speech, which makes it a zone 2. If there's no pause in your speech, then it's zone 1. There's a lot of zone 1, zone 2. 80% of your aerobic workouts should be zone 1 and zone 2. That's going to make you a recoverable machine. That's going to allow you to save your glycogen, your glucose, your sugars for your strength training, for your sprints, for your jumps.
Yeah, and I think the mindset here in the United States, especially in certain high intensity interval groups, are more volume, more volume, more volume, right? It seems to be the answer for everything. But one of the key things is more volume is also predicated on being able to train multiple days. And if you're truly like I was at some point in my life in a burnout phase, you can't get that adaptation because you can't possibly recover.
No, and you may even have
Which
your sleep. You may even have your sleep, your hydration, your stress game together. If you're training too much middle intensity, it's the death. If you're doing too much interval training, you're going to mine your reserves. Your fuel partitioning is all going to go to the limited fuel supply, which is glucose. So we have to do a lot of base training. There's just no way around that. That builds your recoverability for the high intensity segments. But if we're doing sprints, sprints should generally be low volume also. So this high intensity interval training thing can be something you do once in a while. Middle intensity, as little as possible. You're going to do it in your sports if you play tennis or soccer. but your training should have 80% of your sessions be of, of the base variety, zone 1, zone 2, where you can pass a talk test, and realize that it's going to take a long time to build up that metabolic flexibility where you're learning to fuel partition. You're not going to change these things quickly. It takes a long time to change those things, but that's the wealth that we want to invest in, the wealth of lowering our biological age, of improving our sustainable athleticism so that we can deliver forces later in life, and longer in the activities that are important to us, whether it's a 2-hour tennis match or a 4-hour golf round.
I once had a colleague mention the concept that he did not truly believe that folks could be overtrained, that they just were under recovered. And you can argue that it's the same coin, two sides. I'd argue that there are physiological markers like increased cortisol, reduced quality of sleep, reduced restorative regenerative sleep, reduced human growth hormone that can occur. And, that may require you to adapt or modify your next training session. But where do you stand? Under recovered, overtrained, a bit of both? Where do you stand on the topic?
I'm going to pick the third rail, underprepared. So I think recovery is a misnomer. I think that in Austin, there's a lot of people who earn recovery because they're chasing fatigue, or they just ran a 10K or a marathon. So they've earned some recovery. Professional athletes have earned recovery. They're exhausted. We're holding them together with glue and scotch tape and spit, and therefore we're going to use the dry needling, the massage, the lasers. Anything and everything is on the table. And Mark Verstegen at EXOS said it best. He's always going to be about movement, and he's about mindset, and he's about fuel. But his fourth pillar, recovery, is a limiting factor. But that's for elites, okay? For the average person who doesn't hit the PA guidelines, they come in and they see you or me or a physio or a massage therapist, and they're like, oh, I got tight muscles, blah, blah, blah. They want recovery modalities. They want recovery modalities when they're not prepared. So we want them to become resilient. They're in a state of fragility. They think they need to be a vegetable on the table. That's going to lead to this never-ending treadmill for them. We want them to become more robust. And so we want to start with the general simple thing. Let's get 150 minutes a week. Let's see what your resting heart rate is. That's a measurable, I'll find out. And in 6 months, that resting heart rate is going to be lower, hopefully. We want them to be able to maintain a heart rate at a lower level as they break in to a Kenyan shuffle. So imagine, if you will, that you're an ultramarathoner. What would your pace be? That's like a good, for a couch potato, that's zone 3. But for somebody who's fit and not in fatigue, that's going to be zone 2. And that's where the Kenyans do most of their training. So there's lessons from these greats, and should trickle down to urban athletes like you have in Austin, and weekend warriors who don't train for the game at all. And it should trickle down to sedentary people, which is most of the people.
Yep. Let's flip this. We've talked a lot about general health and then wellness concepts and training and different levels of fatigue. Let's start with the injured patient in pain. That's a lot of who we see in the office, and I'm sure you get those too. What do we critically need to know day one, visit one, to assess, treat, and manage this patient? Somebody comes in your door, you see it, low back pain. Low back pain is a common one in our office. What do we need to know to start this process, ultimately to end at resiliency? What do we need to know day one, visit one?
Well, I need to know their story. So I need to know their story, and then I need to validate their story. Then I need to see what their beliefs are. If they believe that they have a herniated disc or degenerative arthritis, that's crucial, because I need to have a conversation with them, and it may take a while to have them understand that it's not wear and tear, that they haven't hit an expiration date, that it's wear and repair. So getting back to your resilience motif, getting back to this issue about adaptation, the number one thing that we're going to want to establish as a goal for them, as a landmark, is relatable adaptation. So let's say it's the back. What is a relatable adaptation? Well, you might say it's doing a plank for a minute. I wouldn't, but you might. Um, let's say let's look at their hip mobility. I love looking at hip mobility. So I always would look at the shin box. I'm going to look at the 90-90, and probably what I'm going to find is there's a internal rotation deficit in one of the hips. That would be one of the things I would look at. Another, because I know you want specifics, I might look at whether they have the fitness to be able to do a high to low plank. I wouldn't expect they can do a 10 RM, but a lot of people are so unfit that they can't even do one high to low plank. So that would be a baseline marker for me. Another thing I might look at is when they do glute bridges, or they do monster walks, or they do split stance kickstands, all things that are designed to target the glutes. Do they even feel the glutes? Now, I'm not going to label them with gluteal amnesia, okay? But I want to know, do they feel target tissue? I'm not going to tell them where they should feel it because they'll feel shame. I just want to know. If they feel their back in the plank, if they feel their back in the glute bridge or a split stance position, that's valuable information for me, and it helps me to determine regressions so that I can program for appropriate adaptations to build resiliency. So those are just a couple of examples. I always look at feet. I always look at cardiovascular fitness. I always look at mobility of key areas like hips. I always look at the pillar like glutes and abs. And then I always look at springs and shocks, the energy storage and release system. So I look at how they skip. Um, and that gives me a foundation in body weight stuff that I can do with anybody and with any musculoskeletal pain. So I'm not siloed to low back. These are universal ABCs. I look at anybody through uh, 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 these five lenses, and I can come up with an on-ramp, a safe starting place that gives them a positive experience with movement of discrete movement snacks they can leave with at the end. So after hearing their story, identifying what their beliefs are, looking at certain hallmark fundamental movement literacies, we always conclude by videoing them, telling them how many sets and reps to do, how frequently to perform a series of very short, no more than 5 to 8 minutes of movement snacks that I want them to perform. And then they get my cell number because I want them to text me any questions they have. I want to know how they're doing, good, bad, or ugly, so that I can support the self-management. So it's that's for the debrief. So we could call that the sixth element.
Fast forward this patient. You've developed rapport. You've listened to their story. You've given them a good, thorough assessment of the whole locomotor system, including, shoulder up, the brain, right? What's your mental state? You got them back. They come in a week later, session 2, maybe session 3 a week after that. What do you need to know about your plan or the patient, session 2, session 3, that would cause you either to stay with the plan or to change course? What
Well,
comes out in that wash?
I know before I even start that I'm not sticking with the plan. Plan B is a mindset that I have, and I know that whatever we start with is safe. I also know it's not optimal. And it's through the debriefing process that we will fine tune the program. So I have to hunt for the appropriate regressions and then see opportunities for progressions to harder things. So when we don't have like a good squat, entry level squat, I have to keep searching because we should all have in our bucket, our trainable menu of squats, we should have 100 things, not 3 or 4. And so we may have a default that we give them on day one that we think is appropriate for them, but it may or may not be appropriate. It's got to be scalable. So it has to be something that they can do on their own. It has to be scalable, that they can add weights to. And then as we're adding weights, we see what their response is. So are they tolerating it? Are they feeling target tissue? If they're not feeling target tissue, I'm going to give them something else. So it's really easy to pivot. But in the beginning, when people have a lot of sensitivity, we're looking for regressions. We're looking for a safe starting place. And then as we progress, specifically what we're looking for after we've given them a positive experience with movement initially, after we found a safe starting place, We're looking for the hardest thing they do well. Those are really the two signatures of my first principles of movement courses. We give a positive experience with movement, and we find the hardest thing people do well. The one is the beginning, the safe starting place. The second is, to your question, what are we aiming at? Where are we headed? What's our progressions? And I don't think in terms of 2 or 3 sessions. I don't even think in terms of 2 or 3 weeks. I don't even know that I think in terms of 2 or 3 months. 3 months is like the beginning point for real change to occur. People always think change is going to happen fast. Tim DeFrancesco, who was the S&C coach with the Lakers for Kobe, you talked about the Lakers before. He is a coach, but he's actually
Talk about gentleman with a work ethic, and talk about how he managed chronic load all those minutes over a course of his career, and
oh
the
my
fact
gosh.
he was able to play that well that long before something happened is amazing.
Yeah, with the Achilles. But Tim, to your point, your earlier point, he's trained as a physio. He's licensed as a physio and an ATC, yet he calls himself a coach. Proudly. He thinks of himself as a coach. And what he says to people when they see him now that he's not in the NBA is, you're not driving a new car off the used car lot. So everything we've done today is safe, but I don't know if it's optimal for you. We'll figure that out. And so we try to avoid timelines. Dan Paff, the great sprint coach and throwing coach, is big on this. We try to avoid timelines if it's not a fracture, and come up with your point about measurables. We want to have landmarks. Landmarks, people need some metrics. They need these measurables. So we focus on the signposts, the rehab criteria. And we're not making progress, we're going to go plan B. It's as simple as that.
Yeah, and then always having a plan B that's right for the patient, right? Like you get that in the intake, and you should start game planning that. What's my backup plan? Um,
Before I
okay,
even go
so
in, before we even
yeah,
start,
yeah,
so if you're going to look at squats or hinges or lunges, Lachlan Wilmot, who hosted me in Sydney, one of the great coaches in Australia, he teaches all of his staff that before you start to do squats, lunges, hinges, core work, glute work, anything else with anybody, you should always know 2 things harder, 2 things easier, and 2 lateralizations that maybe aren't even in that menu but will work the same tissues, so that you're not caught deer in headlights with somebody who's bored because it's too easy, somebody who's afraid because it's too hard, or you're finding that none of these things are working, easier or harder. You got to go lateral. So 2 harder, 2 easier, and 2 to the side. And that's before the session. That's not even after the session.
Doc. So we're in this process. We've gotten visit one. We're in the middle of this process. Several sessions. We've got our plan B, lateralizations, regressions, progressions. We want to wind the active phase of care down. This is the part where a patient they've written their goals, we're at or nearing their goals. What do we need to know to kind of wind down the active where they're seeing us phase of treatment, and then transition them to be independent, anti-fragile, and resilient? What do we need to know to start to initiate this process?
Oh, I love it. So it's almost a curveball, Dino. I believe that from the beginning, we should be Alfred. So from the get-go, we want people to be empowered and to feel that they aren't so fragile, and we guide by the side. So they don't need us. But the silver lining of musculoskeletal pain is that at the end of the day, musculoskeletal pain, while it comes and goes and sometimes is persistent, um, isn't really the ultimate goal. When people come in because of musculoskeletal pain, the goal is to help them realize that we can lower their biological age, that what we should be focused on, because we're in a society where most people are overweight and half of society is either diabetic or pre-diabetic. We are the least healthy hominoids in 8.5 million years. And the reason is pretty straightforward. We move too little and we eat too much. But these are things that can enhance the quality of people's life. And everybody realizes they're living longer, but they're not living better. And now we know that we can actually help people in a way much greater than reducing musculoskeletal pain. Musculoskeletal pain, as I said, is going to come and go. I'm not extinguishing it. I want to make them resilient so that they don't feel fragile, but that doesn't mean they don't have pain. I want them to accept some discomfort. It's just part of life. But what I really want is I want to help them blow out fewer candles at their next birthday than their last. And so we begin this conversation on day one about what Peter Attia says. What you're doing today is your investment in your future. So if you don't want to be an average 90-year-old, and an average 90-year-old is dead or in assisted living, then you can't be an average 50-year-old. And what you do today will determine your health in 10 years. So we are truly now moving into a whole new arena where everything is about expanding health span. We want people to have more
Peter says
vitality. We
shifting
want,
the curve right.
yes, yeah,
Yes, shifting all that stuff further into the lifespan. So instead of you
yes.
starting to get diabetes and all that stuff at 50,
Oof.
you're not worried about it till you're 80 because of the choices you make now.
We want health span to last a lifespan. So back in the day, 100 years ago, lifespan wasn't that long. And health span lasted almost to the end of lifespan. Okay, maybe there was 10 years. Then lifespan got like a lot longer over the last 40, 50 years. And health span actually went backwards. That's the dirty little secret. So if somebody comes in and sees us for musculoskeletal pain, this is an opportunity bypass. A window is open. And that window is for us not to promise quick fixes for musculoskeletal pain. It's to be honest with people. I'm not saying exercise is better than manual therapy or manual therapy is better than pills for musculoskeletal pain. We don't have strong, robust effect sizes statistically for anything for musculoskeletal pain. You know, if anything, what we know is that 85% of all orthopedic surgeries were unnecessary because they are not demonstrated to be better than non-operative approaches. So that being said, what we really should do is we should focus on what we can change: resting heart rate, hypertension. We can take people who are type 2 diabetic and reverse that. We can absolutely make people younger. So as Epstein says in his book on health span, at your next birthday, the number of your candles that you blow out should be less than at your last birthday. And that's the conversation that we want to have with people because of the silver lining of musculoskeletal pain. And I want people to be training for the game. I want them to be good at squatting because you need to squat when you're 90. I want them to be good at getting up and down from the floor. That's a lunge. That's what you need at 75, 70. I want them to have good mobility in their 50s. So I want to get ahead of all that stuff. And those are the things that we're targeting alongside as a dual thing with perhaps why they thought they were coming in the first place.
Um, do you have specific discharge criteria? I, at one point in my career, wrote, when I was in private practice, specific discharge criteria for patients. And it let me know, along with the patient's goals, when to say, see ya, or bye, Felicia, as they say nowadays, right? Moral of the story is I feel like sometimes rehabilitation stops a little too premature. Either pain's gone and see ya, or you're a little bit better, your function's not good, you're running out of physical therapy visits, so pay cash or go home, right? So like, how do we navigate developing effective criteria to say to a patient, you're good, and the only thing holding you back is what's between your ears. But I think from all sense of the word, you're good to go. Like how
So
do
I
we?
had I had a patient who I would say she fits sort of the fragilista mold pretty well, and I've um, I've already released her from seeing me so that she's now training with a virtual group training class. So it's much less expensive. It's in a group setting, which is very sticky. From a behavioral economics standpoint, that peer support, we've seen it in Barry's Boot Camp, Soul Cycle, and things like that, CrossFit. People really
Everything.
thrive in that environment. We hold people back in the tyranny of the clinic. We want people to be liberated. So this woman, she's already been released to the group exercise, and I have discharge criteria. So when pain is the overriding concern, the rehab professional needs to be all hands on deck with them. When it's more about function and less about pain, you want to shift them, as my friend Ryan Chow, who runs Reload in New York City, does, from his physios to his personal trainers. Okay. And if they have flares, they go back to the physio. But she sent me a text. She goes, listen, I haven't skied in like 10 years. Friends are going skiing. Can I go skiing? And Dino, my answer was going to be yes,
Yeah, for
100%
sure.
yes.
Go.
I wasn't going to
Yeah.
tell her no. The fact that she's asking, I know she's thinking it's a possibility. So I'm not going to make her feel fragile. Now, I gave her some guardrails. I said, hey, maybe get a lesson the first day. Maybe ski on the easier slopes, things like that. But skiing's like walking. Skiing's like riding a bike. Like, we don't want to manage ourselves away from those valued life activities with opportunities for social participation. Because the goal, speaking of what you said before, the goal is, what do you want to do? What do you want to do? Well, I want to be playing golf when I'm 70, or I want to be playing soccer when I'm 50. I want to be playing basketball when I'm 40. Whatever that person's goals are, my job is to serve them. But we do have these situations where I'm into people learning to become empowered and have self-efficacy. So I want self-management to always be the goal. But until they're meeting the PA guidelines, I'm going to be supporting them. And if they're an athlete, it goes well beyond the PA guidelines. So if they're an
Yeah,
athlete,
their
I'm not
demand is higher.
I'm not discharging, but I'm going to do what Katie Dabrowski does. I'm going to be focused on their program. I'm not going to be the recovery doc. I'm not going to be the dry needler for what you asked about before with the overuse, which is really maybe under recovery. No, that person was underprepared. That person was spiking loads more than 10% in a week, like Tim Gabbett talks about, or in their off season, they weren't preparing properly. And so what you're calling an overuse was an under preparation.
Doc, if we can get 3 or 4 tips, and I know this is probably a tough one because I think the answer is it depends. I coined that the Stu McGill answer. He loves to throw that out there. But your biggest bang for your buck, you're creating a general program for an individual, like you said, that's not meeting physical activity guidelines. Or second, a person that is meeting some of the guidelines but not fully. Your 3 or 4 biggest bang for the buck exercises or activities that you can give somebody that have the greatest benefit to their overall health status without detracting from their health status. What do you commonly prescribe or
Yeah, so
recommend?
I go back to the world of groundwork. So for me, groundwork is your rehab. We take away gravity, we do body weight, so there's no threat to a person who's lacking confidence. And in the groundwork uh, area, I like the beast crawl with a yoga block, so that it has good technical proficiencies. It gets the heart rate up. It's thermogenic. It's closed chain upper quarter. You're getting a lot of mobility into the transverse arch. Number one. Number two, harder exercise is going to be the sit through. Kind of the icon of the Gracie Empire is the sit through. Now it's kind of like a Turkish get up. Okay, or for those who are fans of ontogenesis, the baby get up from DNS. So that sit through requires hip extension. It's like a single leg bridge. It's shoulder packing. The weight is on one arm rather than in the beast crawl where it's not really as loaded. And number three would be the shin box. So really all from jujitsu. I love the preparation. And the reason I default to jujitsu is because it's the only sport in the world where the ratio of preparation and training to competition is like 4, 5, 6 to 1 in favor of training and preparation. They got Bompa's work about LTAD, long-term athletic development. They got the memo about kids should play and early diversify, and they should train and then they train to compete, and then they compete. And we have too much competition in like 8-year-olds and the
Yeah,
wheels come off,
it's
because then you get all the sports specialization and the pressure from the parents, and it just doesn't work. So those are some 3 bang for buck exercises. But I think even more fundamental, Dino, and I love the question, really is a breathing. Unless breathing is normalized, as Dr. Levitt said, no other movement pattern can be. And getting to our earlier conversation about people are in a sympathetic nervous system state in our society today, in the rat race, especially when they're in pain. So I want to downregulate cortisol. I want to pivot people to parasympathetic, and just slowing the breath, just getting people to practice 5 minutes of mindfulness, to breathe in through the nose and out through thinly pursed lips, to slow that exhalation down. That can help people to lower their resting heart rate and to get them into more of a parasympathetic state. So the most fundamental thing of all really would be to focus on mindfulness and breathing.
Doc, in building a program for resiliency for folks, is there any role now for, this was asked by a colleague that I said, I'm going on with Craig Liebenson today. He's like, can you do me a favor? Can you ask the following questions? So is there any role anymore for static stretching, either as a warm-up or a recovery tool? I've kind of shifted significantly away from static stretching and gone to strength training, and more so eccentric strength training and control personally. However, I do see people in common rehabilitation programs stretch, 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 stretch. It's still out there. What's your thoughts on that?
Yeah, it is. And it goes back to Bob Anderson and a famous stretching book, which you know really well, probably, or maybe it's before your time. But, most lay people, most Gen Pop and consumers, they think they should stretch. They'll even say, I'm not stretching enough. And I think I uh, did the same thing with stretching that I did with like core exercises. I think that I told people, it's no good to static stretch. Like I would tell people, it's no good to do core exercise that way. You need to do it my way. Like your way is no good. Um, Shaming on Pilates or shaming on hollowing or telling them what's the correct way to do it. So I think that the pendulum swung pretty far. Greg Lehman on Twitter is a resource for your colleague. Look at some of his recent tweets about stretching. We now, if we look at some recent evidence, see that stretching isn't so much for flexibility, perhaps. What it may actually be doing, quite surprising, is actually helping strengthen people. And that people who are into yoga, they've always kind of contended that. And there may be some evidence, but I don't see it as a warm up. If you want thermogenic, you got to get your heart rate up. So I like a beast crawl. I like a high to low plank. I like jumping some rope, things like that. That's my warm up. If you're thinking movement prep, something to precede sport, to prepare one for sport, I like to do the warm up thermogenic stuff, but I also want to make sure the feet are online, that there's pillar prep, etc. So it depends what your context is, what your aim and your goal is. But I don't. I stopped a long time ago judging people's choices for their activities. My job is to be an efficiency expert and to see where there are opportunities for improvement. And so I don't have to throw things under the bus in order to find things they're not doing, like enough zone 1-2.
Yeah, and data's pretty clear on that, right? My review of the literature on static stretching is you do not want to do it before a maximal burst activity. It actually impairs your ability in power or dynamic movements. What I found from static stretching on the data is, in terms of injury prevention, it does not do so well. Strength training supersedes any other modality, and probably also proper programming supersedes anything else in the injury prevention realm. As far as a cool down, you can throw it in as a cool down. Most of the benefits of stretching itself are neurological. They come and go really, really quickly. Any short-term gain in range of motion is just that. There may be a role in potentially long lasting duration stretches. We're talking 10, 15 minutes of holding a stretch on scar tissue mobilization, but holding a static pose for that long, there are better utilities for that. But I don't think that the role is once what it was, but I don't think we can throw the baby out with the bathwater, because there's always that one funky situation.
As soon as we do, we're gonna catch an arrow.
Oh
But
yeah.
I do tell people viscosity is important and explain what that is, and preach the motion is the lotion. So it's like with posture. Should we still be shaming people for bad posture? Is there such thing as bad posture? Well, the bad posture is the one you hold too long, and the body has this inherent ability to auto regulate as long as we're moving, as long as we're challenging the body. Sometimes people are in a bad posture, what we call bad posture, because they're relaxing their muscles. This is energy efficient.
Um, when do we start? Like, I remember an example in one of the seminars I took with you, and I was like, how the hell are you going to do this all at the same time? And it was masterful. It was like you were playing jazz at that point in time, and you kind of had the whole audience, in the palm of your hand. How do you? And the example is this: you wanted to look for and find the people that had dorsiflexion restrictions that were true mobility issues. So you basically had all of us doing a kneeling test where we go up against the wall, and hey, when does your knee touch the wall? And then basically what you had us all do is do, all of us, 75 people in a room, core exercises. Go back, repeat your dorsiflexion test. And what you would find was 60 people in the room actually had improved dorsiflexion. Separate those out of the population, come on back, right? More different core training. You had us do different core exercises, planks, modified side planks, rolling planks. You had us do some ancillary things. You separate out that demographic. Then you had us, the people that were left, mobilize that joint to see with further improvement. And you figured out really quickly who were the 5 or 6 or 7 that were the true mobility deficits that needed to hammer mobility. So for the purpose of this question is, for those who didn't get to see that work, how do we identify who truly has a mobility restriction versus truly who has a stability problem?
So Professor Yonda described 5 types of hypertonus, one of them being limbic. Okay.
Yeah,
One being,
true.
connective tissue issues. So 2 ends of the spectrum. One has nothing to do with the muscle at all, and the other is like a connective tissue issue. And Gray Cook talked a lot about what you're talking about in the SFMA, mobility versus stability issues. And one of the things that I spoke with Gray about, and it's recorded and it's transcribed, and it's available for people, was if you use his differential, how do you know if you've concluded it's a mobility issue? Okay, that how do you know it still needs mobility, even in your algorithm? Because that's what we were starting with. We were doing a mobility test. And he said something very interesting, and it took me 10 minutes to get him to say this. He finally said, it may be a mobility issue, but that doesn't mean that we need to mobilize it. In other words, it doesn't have to be a stability issue. You don't need to do stability, but it doesn't have to be something that needs some sort of stretching or joint mobility training. I am now at a place where I think Dre Spina got to probably 25 years ago. A lot of those things where you say we were, taking the group and getting people to kind of flush out different problems. Some of that's parlor tricks. So
Easily fooled nervous system.
yeah, Dre would say that stuff isn't robust enough. And I think I was starting to come around to that in my conversation with Gray. This clear dichotomy, this is a stability, this is a mobility. It never really made sense to me. So generally speaking, for me, if somebody, let's say I talked about, you said, what are a few things that are go-tos? The shin box, hip internal rotation. We all see a lot of people with diagnosed FAI, or a lot of people with a knee issue or back issue, we think maybe it's secondary to loss of internal rotation in the hip. Well, we can go into the 90-90 shin box and we can mobilize. We can do FRC style. I mentioned Dre, Spina. We can do FRC style, which you talked about 10, 15 minutes. We can make it aggressive and hard and burning and, et cetera. But I like to use it the way I showed you in that course. I like to audit. And what I'll do is I'll find things that people can gain confidence in, because really it's not about this is the answer. It's not a holy grail. It's really, can you give people a positive experience with movement? Can you give them hope? And so if we do a Copenhagen adductor, if we work 360 degrees around the hip, if we do a Copenhagen adductor with the medial ankle on the bench, if we then flip it and do a side plank with both feet on the bench, so now we're working the lateral line. If we do reverse Nordic to work the anterior chain, if we do something for the posterior chain, it could be triple extension with like a landmine, or it could be a short sprint or something. It could be a med ball throw. And then we go back. We're probably going to find, and to your point, maybe it's just neurological, but we're going to find that stiffness was a protective reaction. And now, to the theme for today, we've told the nervous system that, you know what, if we can do all this stuff, we're not fragile. So we don't need to protect. We don't need to throw an emergency brake. We're resilient. So when you find the right dose, now if you do too much, it'll stay stiff. But when you, getting back to your Goldilocks question about too much, too soon, too little, too late, when you find just the right stimulus, it's a Viktor Frankl thing. Between stimulus and response is the space, and in that space is your power and your freedom to choose your path. So I'm always kind of creeping up on it, searching for, is this too much or too little? Do I go harder? Do I go easier? Do I go to the side? And just doing a 360 approach just might be the ticket. And now I can give the person one from each bucket because they saw that it helped their shin box.
Using that audit to guide you in real time.
In real time.
In real time. Yeah, that's the power of, what came from the Prague School, I feel, is that clinical audit process. There's lots of gold there, but that in real time to guide you. And to your point, create that early buy-in from the patient, that wow moment. If you're, running clinical practice, that's also a business, you need wow moments.
But it can't be something you did to the person. That's the differential. So if you adjust an SI and the Deerfield test changes, or you say their leg lengths, the malleolus are now symmetrical, or even a fingertip to floor improves, from whatever you did to the person, the fascial release you did, that doesn't empower.
That makes the opposite.
It does the opposite. Makes them dependent on you. And so really it's fool's gold, because the goal is to build self-efficacy, the confidence that you can succeed. That lowers cortisol. And we want people to have something to do on their own, because none of the things we're doing are fixing anything. To the Dre Spina comment, we're not fixing anything. We didn't actually mobilize. What we did was we gave the brain a chance to hit reset. But now there has to be, in the nerve, for adaptation, we need a mantra. We have to repeat it. We got to beat the drum. You're not getting better with progressive resistance training by doing it once. It's progressive resistance training. So there has to be movement
4 to 6 weeks to create. Yeah, 4 to 6 weeks to create a neurological adaptation, and muscular gains, we got to wait 8 weeks, right? Longer, right? So longer. Our little trick for the nervous system may desensitize the area, may turn down your perceived threat in the brain, but it ain't creating a space for anything but that. And then that's when we have to say immediately, if you are doing manual therapy, we have to train this now. We have a window.
And that was why Dino McKenzie was such a powerful revolutionary, because he said, start with the self-generated movements. Yeah. Otherwise, they're not going to be motivated. If you do it to them and for them, you've lost the opportunity.
A couple more questions. What are your thoughts on general versus specific exercises? There's been a lot of debate. I'm McKenzie trained. That's not all I do. I think of that as a great tool for one or two or three things. But there's been a lot of literature out there debunking the role of motor control exercises. They're no better than general exercises. McKenzie-based exercises, repeated extension, repeated flexion, they're no better than general exercises. I argue that there is a role, but you have to find the right utility, the right tool for the right patient. What is your take on it? How do you utilize more of the motor control or end range loading type of exercises in practice?
Well, it's certainly a go-to for a lot of people with discogenic symptoms and sciatica. I at least have to test drive it and see if it's going to lead to some centralization. But I'm not dogmatic about this. Like I just want to find what works. If it's a hip hinge, if it's a body scan from Peter O'Sullivan and breathing exercises, if it's doing some Professor McGill's Big Three, or it's extension, or if it's nerve flossing. I mean, I think that's 5 different things there. I don't care. I don't care. We should all have a lot of optionality because nobody knows. It's like with non-specific back pain. Why is it non-specific? It's non-specific because we don't know.
We don't
That's
know.
why it's non-specific. It's not non-specific because there isn't something causing the pain because it's in your head. No, it's non-specific because it's probably multifactorial. It's probably complex. There's probably more than 1 or 2 tissue reasons. There's probably more than 1 or 2 social reasons. There's probably more than 1 or 2 psychological reasons. And that gives us a lot of options. So we should always have a lot of options. So for physical, and I never ignore the bio, for physical, end range loading is an option. There's a heck of a lot of people that I've seen. The evidence isn't that strong, but I've seen it where there's a heck of a lot of people that come in flexion intolerant, and you get them into a Sphinx on their elbows, and you do a couple cobras. It's painful, but it doesn't run down the leg. You get them doing some standing back extensions, and again, it's painful, but it doesn't run down the leg, and the motion is a lotion. Then their seated SLR is a little better. Their fingertip to floor is a little better, and you're off to the races. But the same thing could have happened with neutral stuff from BackFit Pro. It could have happened with nerve flossing. It could have happened with nerve stretching. It could have happened with breathing exercises. So what I know is I don't know anymore.
Yeah, a lot
I
of
have
gray
to be
area.
open. I have to be open. I have to open to being wrong.
I often will say that's a question for the researchers to sort out. And in clinical practice, we have to find what works for the patient. N equals 1. I know I've heard that from you several times, and I'll throw what I know aside. If in that situation the exact opposite is working for that patient, we'll go that route, right? We want the same thing. I want you up as quickly as possible. I want you as resilient mentally and physically as possible, and I want you to get back to your life, right? And if it's opposite of what the theory says, I'm cool with it at this point in my career. I don't have to be right.
Well, the 3rd edition of ROS, the title is not a practitioner's manual. It's a
Patient.
patient-centered approach,
Yeah.
and that's because of what you said. And we have all this evidence-based medicine, and evidence-based medicine is from population studies, and we have individuals at both ends of the bell curve. So personalized medicine or person-centered care or patient-centered care has to look at each individual as an individual. We don't know if a person is an outlier. We have to assume that what is proven in an RCT is from a study where they assume a homogeneous population so they could get all that statistical significance. Yet we're seeing people in the trenches and everybody is different. We have a heterogeneous population. So it has to be N equals 1.
Yeah. And you can't truly create resiliency unless you program for one person at a time, their unique needs and concerns, right?
That's non-negotiable, by
Yep.
the way.
So we're going to wind this down here, and I've got 2 questions. Over the years, throughout your career, what is something that you thought was true that has been proven true throughout your career and data and literature? What is something you've had to modify? And what is something you're still not quite sure about, like a belief that you've had that it's still true to this day? Something you said, I got to discard that. That's completely wrong. And something that I still have a clinical question on that.
So something I think that stood the test of time is from Dr. Levitt, that rehab is teaching people what to do for themselves. I think that we now see it's becoming clearer and clearer as things have fallen away that high value musculoskeletal medicine is self management, and that's not just for low backs, uh, as Peter O'Sullivan has written in an article about not siloing musculoskeletal pain. If it's true for the back, it's true for the neck, it's true for the shoulder, it's true for the knee as a general principle. Something which we've already talked about, which I believed in strongly and I was wrong, is corrective exercise and motor control. I'm now a firm believer in motor learning, and that we should guide by the side like Alfred, that we don't fix or correct. At most, corrective exercises are, as Charlie Weingroff says, they're like napkins. You clean up a mess and you throw it away. But when you stick with
I've
it and
never
it
heard that
becomes,
analogy.
it's a good one.
And
Corrective exercises are
know,
like napkins. You
a little
clean up
bit
the
about,
mess and throw it away.
what
Don't
about
stick with
Charlie?
it.
Yeah, knowing a little about Charlie in New York, New Jersey, and that rough exterior, it makes sense.
So, I pitched my tent with corrective exercises, and I tell people, and I mean it, burn the second edition of ROS. The first edition is better, and the third edition is definitely uh, has hundreds of pages on complex systems theory and accepting uncertainty, and the humility, which I think is necessary to be able to build trust with people, to find a common ground with people, to see really what their self identity is, and to help people uh, with their own valued life experiences. We want people to feel whole again. We want people to feel hope for their future, and we have to identify how they see themselves. If your identity is in running a marathon, or your identity is playing 36 holes of golf, on a weekend, back to back days, if your identity is in being a runner or doing, a HIIT class, we need to know that. It can't be about us. It's not about our systems and methods. And I think that's something that has stood the test of time. So that's also from Dr. Levitt. He said, "Don't be a slave of methods. Methods should serve the goals. It's the patient's goals."
Closing thoughts.
From
What are your
me.
closing thoughts here? Yeah.
Well, on humility, again, Dr. Levitt, we should keep an open mind for new ideas that sometimes showed what we thought or believed before or taught before was wrong. This is the scientific paradigm. It's about asking questions, about conducting experiments, to fail fast, as a physicist has said. We want to fail fast because we want to be like Sherlock Holmes. We want to rule out the dead ends. And in your language today, to build resilience, N equals one. Well, everybody's different, so we have to have a lot of optionality. We got to be able to find harder, easier, to the side, get into the weeds with that person's context, so it's relatable, so it matters to them. We're listening to their story, determining what matters, then we're assessing them to measure it, and then the rubber hits the road. Can we change it? Can we actually change things that matter to them? Not the Deerfield test. Who cares about that? Something that matters to them. Their ability to go downstairs, their ability to tie their shoes in the morning, their ability, if they have pain at the 5 mile race, 5 mile distance, is maybe, okay, we got two options. We can go slower and do 5 miles, or we can maintain your cadence and do 4 miles. But the goal is your goal. Your goal is my goal. We're going to get there. It's just going to take time. Maybe we have to bike for a little while. Maybe we got to do reverse Nordics for a little while. So this lack of a cookie cutter is my final thought, on top of being uncertain and humble. Don't seek algorithms and cookie cutters and quick fixes. Make it about the person, and test and retest till you get it right.
Doc, where can people find you, and then upcoming courses? How can people reach out to you if they have more information or they want to pursue first principles of movement coursework?
Sure. So Craig Liebenson is Instagram. Craig Liebenson is Twitter. Those are the two best places. You can give out my email address. First Principles of Movement has programs. We're in Albany this weekend, sold out. We're in Vancouver in about a month. We're in a place called the Oval, which holds a lot of people. We will be in Seoul, South Korea in September. If you have a European audience, we're slated to be in Ghent, Belgium in about 2-3 months. And we have a lot of virtual material thanks to the pandemic. We recorded and I edited for 6 months an 18-hour course. I don't even teach 18-hour courses anymore. I realized, let's start Saturday afternoon and let's end at the end on Sunday. And you now have all these things, you have all this content. Everybody knows, everybody has all the same information. Nobody has special knowledge. All I'm teaching is how to make decisions better. And I don't need 3-day courses to teach you how to make decisions better. I got one course, and the course keeps evolving because I'm wrong and I'm failing forward. So retake the same course, but you don't need to spend an extra night in a hotel, and you don't need to not be with your family Saturday morning if you're local. Check us out at firstprinciplesofmovement.com.
And I will post Doc's social feeds in the show notes, and the upcoming coursework and the links towards First Principles of Movement, the website. I've taken his courses before. At that point in time, it was Prague school. And the reality is, I probably am due for an upgrade and update myself. Doc, thank you for being a leader in this profession. Thank you for being a mentor to me. You are on my chiropractic Mount Rushmore, FYI, and I look forward to catching up soon at one of your courses.
Thank you. It gives me chills. Thanks for inviting me, Dino. And it's a pleasure. And I hope to see you in Austin, because I love Austin and I miss it.
If you need, we can see if we can arrange that.
All right. Thank you.
Thanks,
Thank you
Doc.
very much.
Appreciate it. All right.
Bye.